I appreciate Randy Boyd for inviting me to be here today. I'm going to try to deal with this situation of having no computer hookup, so I can't see my slides and have to turn around and talk like this. So I'm going to kind of do it once here. I'm going to get this thing started though. Glad to see somebody else struggling with a computer and it's not me. Okay. Yeah. All right. So I really feel at home. I'm back in the UTK campus. I'm around passionate people who aren't good at keeping within their time slots when they speak either. That's just like me. I hope that my discussion will give some front lines clinical context to some of the things that we've heard about already this week. And I think it's interesting, I got to tag on to the talk that we just had, last night, granddaughter of Robert F. Kennedy died of an apparent overdose. Those aren't marginalized. I mean, they have all the resources anybody in the country have. How could that happen to them? It's not just a moral failing or something like that. So anyway, I just want to add to your point. Okay, so I'm going to ask you to do something different. I'm going to ask you to try to believe in something that at this point you wouldn't believe in, if you're ready. Magic is real. You all need to start using it because there is a dark force that's coming after us. Okay, the laughs and the good, whatever, that's exactly how patients, surgeons, nurses, hospital administrators, insurance carriers, everybody I ever talked to, that's exactly how they take the stuff when I try to tell them what I do and the differences that are out there and what's possible. So lots of the times what they say is, well, I don't even know how to do that stuff anyway. Well, that's not a problem because I can teach you or you can learn. Or they'll say, I don't believe it works. Well, that's one of the reasons I came to the university so I could publish the kind of things that I'm doing. Or they'll say, well, it won't work here because we're not set up. Well, good. Just change the way you're set up. No problem. And then other people will say, well, it's not really important. And I hope with the information I'll show you today, you'll say, I know, we all know that this is important, that we reduce opioid exposure to people. And there really is an element. The machine doesn't want to turn. Why would I change? Status quo is working fine, or change is painful or it's difficult and I don't want to do it. So we've got to find ways to break through all of that. There's my reference to the Harry. What I do is sort of like Harry Potter magic. That's kind of how everybody sees it. So, I was in private practice for 12 years. I actually worked at Oak Ridge for a significant period of time, and that's when I started working a lot with regional anesthesia and really trying to optimize acute pain management. As an anesthesiologist, we try to not knock your teeth out, not kill you, try to get you out of the recovery room, and everything went okay. So if you're comfortable when you leave out of the recovery room, we traditionally would say we've done our job. Well, the role of an anesthesiologist has changed dramatically. We're more pre-testing clinics and optimizing patients and following up in the ICU or in the subspecialty that I'm in and acute pain management. There's a lot more that we can do, and we can change outcomes dramatically. But it's not just some guy that has an idea. You really have to have the system that's bought in. But anyway, Regional 1, or the Med, as you may know it from before, it's the third busiest trauma center in the United States. In about 12, I've been there for 5 years. I thought this would be an awesome place, a national stage to bring attention to these things that I'm currently interested in trying to change practice. Excuse me just a minute as I get myself caught up on this and this. So why do I care so much about this? I'm able to keep this in front of me too. Acute pain control is a problem. If you have poorly controlled pain, a couple of things happen. One, your sympathetic nervous system turns on. That's your fight or flight response, right? But it has a lot of negative physiologic consequences. The other thing is that pain usually comes from, cells have been opened, so you have inflammation. Well, that inflammation causes you to send a lot more signals to your brain, right? So if I poke you with a needle right now, it hurts and it's done. If I touch you, it doesn't hurt. But if you had, an injury on your finger, you had battery acid on it, and then I touched your finger, that actually hurts. And poking it with a needle, it really hurts. But that's the peripheral sensitization. It's doing its job. It's telling your brain, hey, dummy, pull your finger out of the whatever it's in. Okay. But the problem is, if that signal keeps coming and coming and coming, this barrage of nociception starts changing your spinal cord. It starts changing your brain. It's sort of like if you think you saw somebody in the bushes outside, you'd stop and look. And you keep looking, and you'd look, and you wouldn't do anything else. Every time you heard something or thought, you would think something's out there, and you spend too much time on it. And that's kind of what happens. You have a terrible injury, all of this stuff comes in, your spinal cord changes. Then, a year later, I poke you in the finger with no injury. It hurts you more than it hurts me because your body has changed. The other is, in the end, there are all kinds of negative consequences if people are just laying there hurting. And again, one of them is, like I'm saying, chronic pain. The other thing, as long as you're laying there hurting, your opioid exposure is intensified and prolonged. Max Courtney. He's a good kid from a good school, great family. We're good friends, families. We are now. Anyway, Max got injured in a football game, okay? He got sent to another hospital with some broken ribs, apparently, no big deal. Well, he coded in that, and they find out that actually he had a lacerated spleen. So then he was brought to Regional 1. The trauma team took care of him. He's alive the next day. Sorry about that. Anyway. But he looks like crap, right? He's got a big incision on his belly. He's got broken ribs. We had a very rudimentary pain service. Actually, we had just started the pain service at this time, the acute pain service. So prior to that, we had a system set up where they would put a catheter in your back, and it would release some numbing medicine to help with the rib fractures. But you see what's going on. This is not optimal. He's laying there in a mess. I can't even look at Molly's face. Anyway, obviously it's distressing to the family too. So Monday morning, this is what he looks like. We just started the pain service. I'm just going to turn around. I can't see what's going on, okay? This is driving me crazy. Okay, so we just started the pain service just a couple of weeks before. So I walk in, and this is what he looks like. Actually, right before I walked in, Tubby Smith came in for a photo op. Max doesn't remember anything about it. Yeah, no kidding. He's got an IV PCA. He's hitting the button all the time. And anyone who's a clinician know this. His respiratory rate in the step-down unit is 7. 7's real close to 0. That's respiratory depression, no matter what definition you want to utilize. Anyway, you can also see he's got his PCA button right here by his hand. He was having his mom set the alarm because he was hurting, but it was set alarm would wake him up so he could hit his button and get more. And so I said, Mom, this is not going to work. Here's what we're going to do. I'm going to get my ultrasound machine in here. I'm going to look at his belly, his six-pack muscles there. I'm going to put some numbing medicine behind it on each side. The nerve comes around like this. I'm going to stick a needle in there and put numbing medicine in. It's kind of like your belly's like this. The needle sticks in you here. It only goes about this far, but it makes you numb in this whole area right here. So as soon as, and this is what it looks like when we do it. We do it under ultrasound guidance, a very precise sort of thing. This is a video of me doing it here. Skin, subcutaneous tissue. There's layers of muscles. Here in just a second, you're going to see the needle show up. It's going to go right in the right space, and I'm going to inject some local anesthetic right there. And see, it kind of spreads it apart, and then I just drive the needle into that space, then drive it and drive and drive anyway. So that's how we do it. It's a very precise thing to do. Now that we have ultrasound guidance, it's been a huge game changer. So his sister Molly documented everything. You take a look at this later, but see what she says. So that day, right after I got it, literally as soon as I was done, Dr. Magnani's the trauma surgeon, had been taking care of him. He showed up. He saw that I was there doing that, pulled his NG tube out. We got rid of the IV PCA, started doing his incentive spirometer, getting up and walking, eating food at the end of the day. Think that's impressive. 24 hours later, he was entertaining the ladies. So more documenting by Molly. This is Dr. Magnotti, one of the trauma surgeons that I love working with. We got him out on Thursday. And Friday night, he was with his team. So the hospital board recognized me and Dr. Magnotti, one of the nurses, for this, stellar care, blah, blah, blah. So they had a thing at, the Memphis Tigers game, and, they recognized our CEO of their hospital right there, and like, hey, isn't that awesome? And then they put it in the One Pulse. We've got a bunch of articles and these sort of things and blogs and stuff about the stuff the pain service has done. And there's another guy, he had an alcohol addiction. A tree fell on him, and we did our stuff for him till he could avoid being triggered again. So what I told the board at that time was, I really appreciate that, and Dr. Magnotti and the nurse need the attention for what they've done. But next year at this time, I don't want to be recognized for this crap. This should be every day, all the time. Another astute observer will say, you're wearing an Ole Miss hat, and I just want to make sure you understand. Max is an Ole Miss fan, and I'm giving the hat to him right here. I just want you to know I went to undergrad, graduate school, medical school, residency, all at UT, and I'm now a professor at UT. So I don't want anybody to have any questions about where my loyalties lie. All right, this is Roosevelt Taylor. He fell off a tractor 3 or 4 weeks ago. He had what's called a degloving injury. You don't want one. Just tore off the skin and lots of muscle and things like this. So they tried for 2 weeks to save his arm. Ultimately, after 2 weeks in, that's when I came onto the service. They had to amputate part of his arm here just past his elbow. Now look, he's in physical therapy. He's got a smile on his face. You know why? Because he hadn't had any pain in 3 weeks. Because we put a continuous brachial plexus nerve block right here. We just run a little catheter. See, there's a machine behind him. It's got a little button he can push right there if he needs extra. We'll keep him numb the whole time. In fact, a lot of times, we don't even have to take him to the operating room. Well, we take him to the operating room. We don't have to put him under anesthesia. We can keep him, just sort of sedated and all that for all kinds of stuff. So, and he gets really confused after anesthesia. But once we did what we were doing, his wife specifically is like, wow, he's not crazy like that anymore. Well, yeah, that's one of the other positive aspects of this. So this is a video testimonial. I'm not going to play it for you, but this is Max and
hello, my name is Max.
And Molly put this together.
High school.
You can watch it later. But anyway, they're going to have access to that. You should see it. You should hear it from his point of view. So why do I care about all this? You can see some guy's going to lay in the hospital for 3 or 4 weeks, getting narcotics poured on him, on and on and on. Is he going to become addicted? He's got a pretty good chance. It sounds like that will happen, but you don't have to lay there for a month and have a bunch of narcotics poured on your head. If you have a minor procedure to where a surgeon usually doesn't even give you pain pills, but he gives you a week's worth, you're 44% more likely to become a long-term user. Surgery itself is a known risk factor for long-term opioid use, especially in opioid-naive patients. There might be that you had chronic pain for that or something else, but you've given someone that exposure. And you can look at a bunch of the different, someone, I know that's brought the point about had a C-section. Yep, you have increased risk. Total knee, one of the most common procedures, 5 times. And you notice there's a lot of personal factors, history of drug abuse, sure, guys, younger age, on and on. What's interesting is that Chad Brummett, this is something I would have guessed for 10 years, but he reviewed a whole bunch of cases of persistent opioid use after surgery, and he says, yes, it's common, but it's not significantly different between minor and major surgical procedures. Rather, it's associated with behavioral and pain disorders. So you have a little ditzel-nothing surgery, you get exposed to the stuff, and you have an ACE and other predisposing factors. Welcome to the club. Then you've just gotten exposed and you've got this problem. So this suggests that its use is not due to surgical pain for years, but to addressable patient-level predictors. New persistent opioid use represents a common but previously underappreciated surgical complication that warrants increased awareness. Yes, that's what I've been saying for a really, really long time. So if you're in the recovery room or you're going to have surgery, can I predict whether you're going to have a lot of pain? Can I predict whether you're going to consume a lot of opioids? I can't. How do I do that? Well, one would be maybe what kind of surgery you have, right? Yeah, whatever type of surgery, that's going to affect probably how much you hurt, and these hurt more than some others. And who's going to consume a lot? Well, certainly, yeah, the type of surgery probably matters. But if you look at the top 5 factors, surgery type is number 4 or 5. What are the top? Anxiety, psychological distress, preoperative pain, younger age. Yeah, so let's switch lanes just a little bit. Chronic post-surgical pain. So again, I kind of told you how some of that mechanism might come around. It could come from direct nerve injury, but there are other things. So there are risk factors for that. Some of these I can't modify, but notice what one of them is. Depression, anxiety, sure, other pain complaints. I can't really do anything about it. This is the surgery you're gonna have. But if I see these things coming in the door, I should probably escalate care. Like that guy that has a continuous nerve block for longer than most other people will ever need it. I could do stuff like that. I can make sure that he's not exposed to opioids maybe. Same thing, there are some modifiable factors. So if you lay around with a bunch of pain, you're more likely to get chronic pain and guess what? Be exposed to opioids for a really, really long time. If you lay around in the bed for a long time, if you just have a general anesthetic where they don't use regional and block the pain better, that's gonna be a problem. So these are opportunities that I have to modify my treatment plan. And you notice a third of population that are in chronic pain clinics say that the onset was when they had trauma and acute pain. And there are plenty of studies that will show that if you minimize that pain early, right when things happen, avoid just so they don't even know it ever happened, their incidence of chronic pain and therefore opioid exposure is decreased as well. So surgery is a gateway to preventable addiction. So over 400 million patients annually are going to be exposed to the risk of addiction. 6.5%, which is about 2.6 million patients, are going to become persistent opioid users. So somebody said yesterday Tennessee is 2% of our population or something like that. It's 52,000 people. And someone also said that it costs between $13,000 and $17,000, let's just call it $15,000 more to care for those people when they're opioid dependent. That's $780 million every year. Not saying I can make all of that go away, but wouldn't it be great if I took some of that? And if you just looked at the people who, 670,000 in the country, and 2% would be about 12,000 in Tennessee, although apparently we're more than 2%, whatever it is, that's $180 million. That's supposed to be a comma. That's a lot of money that we could do something different with, and the lives lost and the suffering. Surgery accounts for about a third of opioid prescriptions. Just about everybody has some extra pills laying around, and those who misuse, half of them say, yep, that's where I got it. That's an opportunity for diversion. So what if I can push you out of the plane, but I gave you a parachute? I'm gonna give you a parachute that takes you all the way to the ground, everything's okay. But if I just give you a parachute that brings you down to 100 feet and it goes away, you still fall, right? So what if I could keep you comfortable all the way through surgery, all the way afterwards? You're alert, you're awake, you're avoiding narcotics for side effects and exposure and all those kind of things. You go home early, and you really haven't needed anything. In the end, you've never really needed any narcotics. Wouldn't that be cool? What a fantasy. How that sounds magical. We do it every day. We should do that more often, but that's just where we are. So what are the tools that I use? I kind of alluded to these continuous peripheral nerve blocks and multimodal analgesia. So there are guidelines already that the American Society of Anesthesia and the American Pain Society and American Society of Regional Anesthesia have put together. I've sort of summarized this from a brilliant paper from an author. A couple of things that we say is, yes, you should use regional anesthesia, the numbing medicine stuff. It is the most effective thing that we can do to control pain. And you should utilize it more and more. So if it's a little nothing surgery, sure, just put some local anesthetic in the incision. But if it's a bigger thing, maybe you should do a nerve block. Maybe if it's a big thing that's gonna last a long time, you should use a continuous nerve block, possibly an epidural. The other thing, this drives me nuts. You know, the World Health Organization has the stepwise, it hurts a little, give them this, it hurts some more, give them this, it hurts some more. All people do is they go, narcotics, some more narcotics, IV narcotics, make it a double narcotics. They just go like this. They use opioid monotherapy all the time. So what they say is don't do that. Start with scheduled non-narcotics. Tylenol is not that strong, but if you use it regularly, it's actually pretty strong. If you add to it ibuprofen, Toradol, some other non-steroidal, you put all that stuff together, however much narcotics you need. It's not IV narcotics. You're not like, it's like, why would you go straight to that and then just go farther and farther? But it's just kind of a way that people think. These things like Tylenol, they're not that strong, don't bother. And anything. Anyway, so you should schedule them and use them all the time. You should be thinking about subpopulations of patients that are at increased risk, and that can be for opioid exposure. It could be for an ileus developing or chronic pain or whatever it is. But you should think and modify your acute pain management based on who these patients are. And then you have to actively educate patients and family about the plan and expectations. Most common thing is this, like the guy with the block in the arm, or Max, either way. When we put the numbing medicine in, it was a sharp, burning, terrible pain. Now he still feels something, but it's pressure. It's pressure and tightness. You know, when you're walking in the woods and a spider climbs up your arm, you freak out like this, and then you look and it was just a tree. And you walk a little and you get the same sensation. The third time you feel the same thing, you ignore it because you know it's nothing. They feel pressure, and if you don't educate and talk about what's really going on, they'll say, oh, I feel pressure, and they'll use that stupid pain number thing. What's your pain number? 10. Oh. And then the nurse has to go give them something like that. So you have to educate them because the best system is not going to work if everything is not together. So this is not the time to talk about multimodal, but I mentioned that we have all kinds of tools that can drop opioid use by 30% in and of themselves, or, IV lidocaine right after a bowel surgery can drop local, opioids dramatically, which is interesting that, gabapentin we use for all kinds of different things, and it's helpful in acute pain, but now apparently, I don't know, that's starting to be something that's being abused or something like this. But anyway, we have lots of tools. So how do we treat pain in general? So previously, the main tool you would have be systemic medication. So take a pill, shot, and some kind of IV. That affects your whole body no matter where you're hurting, and that's great. But some of those things, I said, well, they're relatively weak. They have their own side effects, opioid-related adverse drug events, and of course, addiction, diversion. Opioid-induced hyperalgesia, which you kind of mentioned before, they always hurt. They're always touchy. A little bit of pain really hurts. Yeah, when you take narcotics for a while, your body sort of resets, and it doesn't reset the other way. So you have to take their condition a little more seriously. Well, that's okay. In the 80s, we started really using epidurals, lumbar and thoracic epidurals. We can make you numb in that area, but it makes you numb all the way down. There's some other issues about putting a needle real close to the spine. You have to, some other things that come with it, but it's effective. You can't get it to go much higher than your collarbones, though. So your arms, we're not going to work for that. Today, again, like I say, the most effective thing we have is local anesthetic, and it's about how you use it. So surgeons might just inject some local anesthetic around a spot. That has some value. There's some formulations that would last a little longer, 2 days or 3 days, supposedly. It's debatable. Or, again, they're short-lived, and that's the problem. You can do a single shot in nerve block where you just put, hey, you're going to hurt right here, so I'm going to put the numbing medicine here and make all this stuff numb and everything's fine. If that's going to last long enough, just giving you another example, I can put numbing medicine right here and another one behind your leg. We could cut your leg off right there. It doesn't hurt at all. I can keep you numb until that terrible inflammation and everything goes away. Problems. But to do this continuous nerve block stuff, it is the most effective thing we can to turn off pain going to your brain, but there is still an inflammatory response that we have to work on. So actually, doing the local anesthetics with this stuff that wasn't so strong all by itself, it's a very powerful combination. Problem is, you can't just put in a nerve block and a catheter and roll these things and just push them out in the parking lot. You've got to manage that. So the newer perspective on things is to have an APS, an acute pain service. That's someone that's actively managing and paying attention and talking and educating. The problem is this: I'm an anesthesiologist. I make a lot more money for the hospital if I just stay in the operating room. I get a little bit of nothing for rounding, a little bit of procedures out here and there. It's not doing consults, and it's labor intensive. People don't see it. I say this, hospital administrators don't see that as valuable because, Jerry, you're not generating a lot of money. I say, no. Who cares about the money I'm making you? I'm saving you millions of dollars by avoiding opioid-related adverse drug events, by keeping people from getting triggered, from becoming addicted along the way. I get them out of the hospital faster. I get them out of the ICU faster. That's what it is. But like someone mentioned, people pay for things you did, not what you prevented. How do you say I get paid for a thing that didn't happen? And was it you that did it, or how do we know that? We're early in that. Thank you. So pain service is supposed to optimize analgesia. There's a lot of benefits to that. Plus, I think it's just the right thing to do. All right, we minimize opioid consumption, so that's side effects and addiction and diversion. Try to get them out of the hospital in a better situation. It would be awesome if we could set this up. Maybe what if I could identify these people that are at risk, or they really are currently have opioid use disorder and they don't have anywhere to go? What if I could catch them right now while they're having surgery and hook them up to the right people they need to do? And while we're paying attention, yes, it does have a significant financial effect. So when I first got to UT, I asked the trauma surgeons, who are the patients you had the most trouble with? And they said, it's these young guys that get shot, get a big belly incision like Max had, and they lay in the bed with their butt, and then they push it all the time. Their bowels never wake up. Their opioid consumption goes through the roof. A month later, they're healed by a long way, but they're taking all these narcotics, so you can't get them off, and we got to send them out with all these narcotics. Okay, good. So what I did is, while I'm on trauma call and something, I would put these nerve blocks in like I did for him, and we retrospectively looked at a bunch of these patients and control matched them with 2 to 1. And what we found is in the first 3 days, statistically, in a statistically significant way, I decreased opioid use. This is the period of time that the numbing medicine infusion was going on. I wasn't managing the patient. I just put the block in, the surgeons gave them their narcotics or whatever they did. But you notice after that, it goes right back up. So now I'd say, oh, that's great. So we got it accepted as an abstract. We're slowly trying to get it published. So we statistically made a difference. But right now, if you told me, hey, isn't that awesome, Jerry? You did that thing, and people are only taking 173 morphine milliequivalents in 3 days instead of 248, I'd say, that's pathetic. Now, patients come in for that kind of surgery, no narcotics during the surgery. I put the blocks in before they wake up. We keep the infusion going the whole time. They don't take narcotics at all. It's bizarre if any of my patients of any sort had to resort to IV narcotics. So here's how it works. Kind of the local anesthetic infusion is the foundation. We give the scheduled non-opioids in the background. That's how you do that. They've got a button they can push that gives them more numbing medicine if that thing is hurting. We can give them PO or by-mouth opioids if needed. If they're going back to surgery and it's something going to hurt, I can put some extra in there, do something. Worst case, maybe they do get a little bit. Or get rid of all this crap and just give them all of this. That's the status quo. But that's easy, that's known, that's what we have. That's where people still think. The other piece is, this is the strategy, but it takes a lot of the counseling and education that really make all of this stuff work. So we get a lot of chest wall trauma in my hospital. And this is just kind of, these are patients with isolated chest wall, a bunch of broken ribs. That happens for all kinds of reasons. If you think of this as just sort of the mildly injured, moderate, and severely injured, there's a percentage of people that go to the ICU, there's a percent that get on the ventilator. Okay, so you're really injured, about 40% go to the ICU, half of those get on the ventilator. After we started doing this nerve block thing with the continuous infusion, and especially as the pain service came along, we started collecting some more data. This is the new data. Same categories, ICU, none, ventilator, none. And you'll notice even the people that aren't that injured, not so bad, they still sometimes end up on the ventilator. That's because, the little lady falls down, breaks a few ribs. Yeah, that's an awful thing, and they die from that. So there's lots of good reasons to control pain well. And in fact, these numbers are going to be better because we don't even have the last year and a half or so of our data when the pain service is there monitoring and managing and really doing a lot of stuff. So we've even got more to do. So we kind of, for chest wall traumas, we figure out what nerve blocks do we do? Are they broken in the front or the side or the back? And we figure out what continuous nerve block to do. We have a standard regimen and as needed. Again, it's very rare that even these awful patients, nobody ever needs IV narcotics. Maybe an oxycodone or 2 or something like that. So this is an example. This guy he told me it was a 2,000-pound pipe. He says 1,500, whatever. Pipe fell on this guy, came in. He has left rib fractures 1 through 6 and 9 through 12, including a flail segment and a chest tube. He's got rib fractures on the right and his sternum's busted. When he came in that night, the pain was worse in the back, but they couldn't get him to roll over to do one of the nerve blocks back there. So at night, somebody put in what's called subpectoral blocks, continuous subpectoral blocks, and that makes you numb across your chest like this. You could do the same thing. You could do a full sternotomy, for heart surgery, no pain, pressure. Anyway, we did that for him, got the multimodal going. The next day when I came in, he was feeling a lot better. He was able to roll over on his side. I put a paravertebral block in like that, and all of his pain was controlled. Actively working on his incentive spirometer, coughing, walking, moving, going home early. Everything's cool. So I turned 50 on July 14th. My wife set up this awesome trip out west, and this is on my birthday. This is John Hovey. He's my paraglide instructor. I'm a junior instructor or something like that. But anyway, we had an awesome time. So it was a long trip, though, on the gondola, whatever the gondola thing is up the hill. So like all guys, we're sitting there together. It's just he and I. And, of course, we start talking about regional anesthesia and multimodal analgesia like everybody does, right? We get to the top. He's like, you know what? Actually, my brother's in the hospital right now. He's in a motorcycle wreck. Somebody illegal U-turn and hit him, busted a bunch of ribs and all this kind of stuff. And he's like, he's hurting like crazy. He won't take any medicine at all, though. He's doing on and on. The conversation goes a little farther. As it turns out, Hovey's brother got addicted to pain pills so many years ago. He climbed out, okay? He made it, he's moving along. He is scared to death that he's gonna get triggered and go right back in that. And that's not just like, oh, your life's gonna be a mess. People die every single day of drug. I mean, so if you get this guy triggered again, and he's like this, and his jaw just dropped open, he's like, why isn't everybody else doing this kind of stuff? And I said, that's what I've been saying. Why do we just give everybody narcotics and go, well, good luck? Why do we do that? Well, I hope SOAR will help me make this more important. Everybody pay more attention. Again, I can come up with the cool how to do this stuff, but it's not me. It's a system that makes it work, right? I've got to have the nurses that know what to do. The physical therapists are on board. The surgeons know where this. We've got to have a system that works. So that guy that had the pipe that fell on him, he sent me these T-shirts, Dr. Numb. That's awesome. He sent a letter with it. So why doesn't everybody else do this? Doesn't this sound awesome? Well, I got you these T-shirts. My bill with you is in litigation with the company I was working for. Is insurance not going to pay for it? Sure. Now, I'm going to do it because it's the right thing to do, and I love it, and this is my passion. Do you think 99% of the anesthesiologists are going to learn new tricks, and somebody's going to say, yeah, quit working in the OR. Go out there and make no money, and nobody's going to get reimbursed for it anyway? No. So we've got to have change, or what this stuff is not going to turn on. But despite the unending days and the struggles to gain legitimacy and support for this underappreciated medical service, every genuine smile and tear from a grateful patient pushes me to do what I can to make this level of care so common and routine it doesn't need a champion. So the reason I'm here is Randy Boyd put something on Facebook that said, hey, I'm going to give all these millions of dollars to people with drug addiction. And I made a comment. I was like, that's awesome. I can think of a return on investment. It would be just as good. Why don't you help me on the front lines? These people that have fallen in, they need help. But why don't you help me keep them from falling in the first place? And then what do I do when someone did fall in and they're like Hovey's brother, they got over it, or they're just battling it and they come back? What do I do with them? I need more attention and resources and focus. There we are. So that's what I have to say about that. Thanks, guys.